Hello, today we are going to discuss on portal hypertension in children. Portal hypertension means when portal venous pressure is more than 10 to 12 millimeter of mercury. The normal portal venous pressure is 5 to 10 millimeter of mercury, and when it is more than 10 to 12 millimeter of mercury, it is known as portal hypertension. Sometimes hepatic venous pressure gradient is used, so when this is more than 4 millimeter of mercury, it is considered portal hypertension. There is another terminology known as portal pressure gradient. This is the pressure gradient between the portal vein and inferior vena cava. So when this is more than 10 millimeter of mercury, this is also considered as portal hypertension. PPG, when it is more than 6 to 10 millimeter of mercury, there is subclinical portal hypertension. That means there is no clinical symptoms. PPG more than 10 millimeter of mercury, the varices occurs, that is engorgement of the vessels occurs. And PPG more than 12 millimeter mercury, varicose bleed occurs, and then child may also have ascites. Portal hypertension occurs due to these two causes mainly. These two conditions leads to portal hypertension. Number 1, increased portal resistance. Number 2, increased flow of blood through the portal system. So out of this, number 1 is more commonly seen or more common cause. Now come to the anatomy of the portal vein, or few important things about the anatomy regarding portal hypertension. Portal vein, it is formed by superior mesenteric vein and splenic vein, which join behind the pancreas to form the portal vein. And this portal vein is draining intestines, stomach, spleen, pancreas and gallbladder. Now come to portocaval anastomosis. Very important to understand the portal hypertension, or to know about the clinical features and management. So there are 5 main portosystemic circulation in regard of portal hypertension. Number 1, at the lower third of the esophagus. Number 2, paraumbilical area. Number 3, upper end of the anal canal. Number 4, retroperitoneal area. Number 5, bare area of the liver. So number 1, gastroesophageal junction. Esophageal varices occur here. Left gastric vein coming from the portal side and branches of the esophageal vein coming from the systemic side are anastomosing. So the engorgement occurs here, and then the varicose bleed occurs in portal hypertension. Number 2, umbilicus. Paraumbilical vein from the portal side. Epigastric vein from the systemic side forms the caput medusa. Then anorectal junction. Superior rectal vein from the portal side. Inferior and middle rectal vein from the systemic side forms the hemorrhoids, and there might be hemorrhoid bleeding during the portal hypertension. In the retroperitoneal area, hepatic and splenic fixture. At the hepatic and splenic fixtures, omental and colonic vein from the portal side, and then retroperitoneal veins from the systemic side are anastomosing. And at the bare area of the liver, intraparenchymal branches of the portal vein from the portal side, retroperitoneal vein from the systemic side forms the retroperitoneal collaterals, and these rupture during portal hypertension. Now come to classification and etiology of portal hypertension. There are 2 broad classification. One is extrahepatic, another is intrahepatic. Extrahepatic portal hypertension is again divided into 2: prehepatic, known as pre-sinusoidal; posthepatic, known as post-sinusoidal. And intrahepatic portal hypertension, it is hepatic causes and then also known as sinusoidal portal hypertension. It is noticed that in the developing countries, 50 to 70% cases of portal hypertension is due to extrahepatic type. So extrahepatic portal hypertension is more commonly seen, and this is predominantly seen in children less than 5 years old. In the developing countries, hepatic causes are predominant. Now come to the different etiologies. Extrahepatic causes or pre-sinusoidal cause occurs due to obstruction at the portal, splenic or mesenteric vein, and this obstruction can occur due to the following causes. So number 1, at the umbilical vein infection, and this is the most common cause of extrahepatic portal hypertension in case of children, and this occurs due to umbilical vein catheterization during the neonatal period. So you have to be very careful to do the umbilical vein catheterization in the newborn. If infection occurs, then long run they might develop portal hypertension. Portal superior mesenteric or splenic vein thrombosis, they can cause. In the hypercoagulable state, this thrombosis can occur, and this can occur due to acute dehydration, polycythemia, deficiency of anticoagulant proteins, mainly protein C, S and antithrombin 3. Number 3 cause, congenital portal vein agenesis, atresia or stenosis. So these are the anatomical defects or malformations. And then extrinsic compression due to pancreatitis, malignancy, portal lymphadenopathy can cause prehepatic portal hypertension. Another cause is trauma to portal vein. Number 5 cause, increased portal blood flow occurring in the arteriovenous fistula, which can be congenital or acquired. Number 6, most cases are idiopathic. So 2/3 cases of portal hypertension, the cause will not be detected. So in these conditions, these are known as idiopathic portal hypertension, and 2/3 are of this type. Number 7, massive splenomegaly. Now post-hepatic or post-sinusoidal causes. This occurs due to obstruction to the blood flow at the level of hepatic vein, which occurs in Budd-Chiari syndrome, chronic right heart failure, constrictive pericarditis, inferior vena cava obstruction, which may occur due to web, bands, strictures or external compression, veno-occlusive diseases, and sinusoidal obstruction syndrome. Now come to biliary tract diseases, which are also causes for post-hepatic portal hypertension. In this, extrahepatic biliary atresia, choledochal cyst, sclerosing cholangitis, idiopathic portal hypertension are the causes. Number 2, now intrahepatic portal hypertension can occur due to hepatocellular disease. So problem in the hepatocytes. So main cause is cirrhosis. Cirrhosis can occur due to all these following conditions. Number 1, infections, which may occur due to viral hepatitis B, C or in the chronic liver disease. Metabolic disorders like Wilson disease, alpha-1 antitrypsin deficiency, glycogen storage disease type 4, cystic fibrosis, Gaucher's disease. All these are inborn error of metabolism genetic diseases, which are usually diagnosed in the childhood period. Infiltration due to leukemic cells, lymphoma or sarcoidosis can also lead to cirrhosis and leading to hepatocellular disease and portal hypertension. And then hepatic malignancy is another cause. B, hepatotoxicity due to arsenic poisoning, hypervitaminosis A or methotrexate. C, congenital hepatic fibrosis. D, biliary tract disease, primary biliary cirrhosis, intrahepatic bile duct paucity can be the cause. E, sclerosing cholangitis. F, idiopathic portal fibrosis. So many times idiopathic portal fibrosis is cause for portal hypertension, intrahepatic type. Now come to pathophysiology of portal hypertension. It is extrahepatic or hepatic type. So in the ultimately the main pathophysiology is same, that is increased resistance to portal venous flow. But initial part is different. So extrahepatic, there is first portal or hepatic vein thrombosis obstruction, which leads to increased resistance to blood flow in the vessels, leading to portal hypertension. Whereas in the hepatic causes, first problem occurs in the hepatocyte before it involves the vessel. So there is cirrhosis, which leads to scarring. Perisinusoidal deposition of collagens are there. So this scarring leads to narrowing and compressing of the hepatic sinusoids. Fibrosis occurs, which compresses, so there is progressive increase in the resistance to the portal venous flow, ultimately leading to portal hypertension. And another cause can be portal pressure increasement, or if there is increased portal pressure. This results in dilatation of the venous tributaries and development of the alternate channels, that is, the collaterals develop at the anastomosis, and for shunting of the blood from portal to systemic circulation, that is the portosystemic anastomosis. So when the pressure increases, the vessels at these sites rupture, leading to the bleedings. Thank you. We'll come with the clinical feature in the next class.